who are the participants. YouTube में live जाता है.
Yeah, live.
Good evening, everyone. Welcome to the iFocus online lecture 418 of the Cataract module. Today, in this class, we will be studying about the femto laser assisted cataract surgery, the indication, contraindications, techniques, and complications. For the session, I would like to welcome our moderator, Dr. Kiran ma'am. She finished her MBBS from BJ Medical College, Ahmedabad. She's an MS Gold Medalist from MNJ Eye Institute, Civil Hospital, Ahmedabad. Ma'am did her senior residency from DDU Hospital, New Delhi. She's currently a senior consultant at Center for Sight Eye Hospital, New Delhi. Ma'am is trained and certified femto cataract surgeon and a refractive surgeon. She is also the organizing secretary of prestigious PG training program iFocus, also the organizing secretary for IC, faculty for iFocus, IRC, and various other conferences. Ma'am has authored multiple book chapters and publications in index journals, both national and international. Welcome, ma'am. Over to you, ma'am.
Garvita, and welcome all of you to another session of iFocus. I would like to introduce our chairperson for the day, Dr. Rishi Mohan. Sir has done his MBBS from Maulana Azad Medical College in 1982 with a gold medal, and thereafter he finished his MD in ophthalmology from RP Center AIMS in 1985, followed by DNB in 1986. He did his senior residency from RP Center itself in cataract and cornea, and followed that with the fellowship with Project Orbis in USA as staff ophthalmologist in 1989. Clinical registrarship in Prince Charles Eye Unit K7 Hospital, UK, and his fellowship is also from Royal College of Surgeons of Edinburgh in 1996. Sir has been awarded with membership of the Academy of Medical Sciences in 2006. Recipient of various academic awards, the Maulana Azad Medical College Gold Medal and Certificate of Merit for First Position from Delhi University, the Best Resident Award for RP Center for Ophthalmic Sciences in AIMS 1986, and he has also held various prestigious positions in national and international authorities. He's been a member of Scientific Committee, All India Ophthalmic Society, Joint Secretary, Eye Bank Association of India, Secretary, Indian Society of Cornea and Keratorefractive Surgery, Treasurer, Eye Bank Association of India, EBI, President DOS from 2016 and 17, and Vice President ISCARIS from 2016 to the current times. Coming to our speaker of the day, we are all very, very lucky to be hearing from him, the man who needs no introduction and all words will fail. So, but just to introduce him, Sir has done his MBBS from AIMS in New Delhi and MD Ophthalmology, where he stood first, from RP Center AIMS in 1984. Sir has finished his senior residency also from RP Center AIMS. His fellowship is in cornea from Georgetown University, Washington, DC in 1990. So was Associate Professor, Dr. RP Center AIMS, before he founded and promoted the Center for Sight Group of Eye Hospitals. Currently, Sir is the Senior Consultant, Chairman and Medical Director, Center for Sight. Awarded Padma Shri by the President of India in 2007. Sir has been past President of AIOS and JAWS. Having pioneered the technique of Phacomorphic and LASIK in India, Sir has been conducting and performing several live surgery demonstrations in the remotest locations of India, and we are all proud to have learned from him. Present positions being held are Sir is Chairman of the Scientific Committee, IRSI, Chairman, Editorial Board, Indian Journal of Ophthalmology, Member of Managing Board of Indian Red Cross Society, New Delhi, and Chairman, Trade Subcommittee of AIOS. So before we proceed for the lecture, I would just request Rishi Mohan sir to speak a few words.
Well, thank you so much, Dr. Kiran. I'm very happy to be here again. It's an honor, in fact, to be able to chair a session in which Mahipal is speaking as the main speaker, and on a subject where I think he's the one who's actually pioneered it. And we've all learned from him. And it's ironic that I'm sitting in the chairman's position here, hearing Mahipal speak and obviously learning from him, because he has pretty much shown us the way forward as far as flax is concerned. So I think flax is the technique that is really taking over. The penetration is increasing every passing day, and I think it's imperative that the youngsters learn this technique, and if you learn it well, I think there is a lot of value in it. And I think it would be advisable for all those listening to this to hang on to every word that Dr. Mahipal says, because he is going to tell us how exactly to do this procedure, what to do, what not to do, and how it's different from conventional cataract surgery. So over to Dr. Mahipal. I'm all ears.
Yeah. Well, good evening, everyone, and thank you very much, Rishi and Dr. Kiran, for the kind words. I'll be talking about the FLACS, or the femtolaser assisted cataract surgery, as it is called or as it is known. So what I'll just wish to say is that you need to actually look at what cataract surgery was, how it has evolved, and what it is as things stand today. So basically, there are a lot of learnings that we had from the cataract surgery that was there. The cataract was first described or referenced, I would say, in the ancient Babylon, that is 250 BC. And then the eye disease and treatment was recorded by the ancient Egyptians. But if you look at India's contribution, 300 BC to 500 BC, if you look at it, the Shushrut, as one would say, he had a full chapter on eyes. That is Ultra Tantra. That's what it is, and it is written by Shushrut. And I would say that we have come a full circle from a no-stitch cataract surgery at that particular time to a no-stitch cataract surgery today, as is the standard of care today. Then you look at it being called by the ancient Greek as the systemic human body dissection included. This was described by the Herophilus, and then Rome comes and went on to the era of Renaissance, where the 1851 it really came back, and then the Helmholtz described the direct ophthalmic. And then 20th century, I would say Charles Kelman, whom we lost very recently. In 1967, he came up with this technique of phacoemulsification, and from phacoemulsification, we have added on and moved on to the femtolaser assisted cataract surgery. Now, as I told you, the first thing that has been described is called as couching, which was 5th century BC, wherein one waited for the lens to mature, where a person was almost absolutely blind, and one would actually displace the lens into the back part of the eye, that is the vitreous. And then, mind you, extracapsular cataract surgery came first, and then there wasn't the wonder drug of steroids, and there was the issue of the kind of reaction that was there, which actually took it out. And then the intracapsular cataract extraction came, and intracapsular cataract extraction, then it was modified. Smith Indian, again, India has a great role to play there. And Smith was working in Chennai, I think, when he described the modified Smith Indian technique that is there. And then came the cryo, and I still remember we were residents when the cryo came in, and it was considered to be the very best technique that was there. There couldn't be anything better than a cryo extraction for removing the lens in toto, that is the intracapsular cataract extraction. Then Charles Kelman came up again with the idea of phacoemulsification. Obviously, the fluidics were not that good. There weren't any viscoelastics at that particular time. There was very little knowledge about the irrigating fluids, etc., etc., and it really didn't pick up. But then I think it was in the early 90s that phacoemulsification, late 80s, early 90s, that phacoemulsification started picking up. And that's where I actually saw it in the US. People were working on the phacoemulsification, and then came back to RP Center, Ames, and procured the phacoemulsification machine and went on. Phacoemulsification was obviously costly at that time. People did not think that it was a great technique, and therefore, again, India came in, and it was largely India, Israel, and Nepal, where this technique of the small incision cataract surgery was taken up. And there, again, the basic guiding force was quick visual rehabilitation with target emetropia as to how to make it astigmatically neutral, etc. And then from there on, from phacoemulsification, the incision kept shrinking, and then we came on to the micro-incision cataract surgery, which was there. So, friends, this is what the couching was, the earliest form of cataract surgery introduced in India. Was very popular because a person who was born blind would actually come and see. This is Shushruth, and these were the instruments. So, mind you, look at these instruments. These are pretty much one would, if one has to design these instruments, or as they are designed today, the needles, etc., etc., or the lancet, as you can see, this is pretty much carried on, and this is how it was done. And this is the one of the videos that I could get on the net, and you can see this is how it is, that the zonules were supposed to become lax as the cataract went on to mature or hypermature, and this is the lens was displaced back. Now, when you look at cataract surgery, when even at that time of couching, I would say that was a no-stitch cataract surgery, and as I have shown you the evolution to small incision cataract surgery has changed significantly from not being a restorative surgery only, but has become a refractive cataract surgery. And you can as much visualize, because today there is something which is called as PLEX, or presbyopic lens exchange, or refractive lens exchange. That means that the results have so improved significantly that one is looking at correcting presbyopia by the same procedure of cataract surgery as one does for people having cataract. So this today is refractive cataract surgery, which is, and why I'm talking about this is that the femtolaser is a step forward here. So refractive cataract surgery gives you good vision, plus eliminates or significantly reduces the dependence on glasses, both for distance and reading. And the demand for refractive surgery around the world is growing significantly because people wish to not be dependent on any encumbrance, and glasses is an encumbrance to people. Now, let us just understand that this is, as of today, the uh, the frontier, or the final frontier today, but I'm sure this is going to change. But femtosecond laser, what exactly is a femtosecond laser? A femtosecond laser is a laser which is around 1000 plus is the wavelength. And then if you look at the femtosecond laser, it derives its names from a quantification of time. A femtosecond means 10 to the power minus 15th, or 1/4 of a second. So therefore, it is a very high energy laser which is fired for a very brief period of time. And because it is fired for a very brief period of time, the total quantum of energy that is put into the eye is very little. The femtosecond started with working on the cornea for making the flap. And today it is the same femtosecond which is being used for making the denticule extraction, which according to me is also becoming the standard of care. So similarly, by changing the numerical apertures and by changing the focusing mechanism, you are able to focus the femtosecond on different parts of the eye, that is on the lens. So the femtosecond laser actually pushes tiny bubbles like this, which hit a surface, and they tend to expand. As they expand, they produce plasma, and they produce gas. And these gas bubbles, when they join each other, once after they are expanding, they form a contiguous layer. So once you are putting these spots which are there, this is the initial beam of the spot, a cavitational bubble is formed, plasma expands, and this is called as laser-induced optical breakdown. So this is sharply focused as ultra short duration that generates plasma, and this is the cavitation bubbles which are formed, which is there. Now, in the femtolaser, therefore, you are making cleavages in the capsule, you are making cleavages in the nucleus, you are making cleavages in the cornea. So you are making the incisions and the arcuate incision. So these are 4 steps. Normally, almost all the lasers that are available does the first step, which is a capsular excess. The second step they do is a lens fragmentation. Third step they do is the incision, the primary and the secondary. And fourth is if there is a requirement for astigmatic correction. Normally, femtolasers, we work on astigmatic corrections up to a diopter or a diopter and a quarter diopter. Because after that, because of the stability being better, you do on a lens-based toric correction, that is a toric intraocular lens. So, as I said, as I traced the history and as people have gone on to the cataract surgery becoming a refractive procedure, so therefore this is one of the goals that is looked at by the femtolaser or the femtocataract surgery being able to establish this particular role, making it into a refractive procedure. So as I told you, this is the rough guideline as to the 4 parts that the cataract surgery done. Often there is debates that come on that, is phaco better or is femto better? You have to use a phaco at the end of the procedure. And it is basically, I would say, these are complementary and supplementary technologies. It is not that one is versus the other. It is a complementary technology to each other. And therefore, it makes the surgery more precise, more comfortable, and looking at outcomes which are very good. At times, the people say that it makes a great surgeon, an average surgeon, and an average surgeon a great surgeon. So that is up to you. How do you decipher? But if you have to get repeatable results, if right from day one you want fantastic capsular excess, round, whatever size, shape, wherever you want to put it, that is going to be achievable by the femtolaser which is there. So one of the biggest things that is the advantage of the femtolaser is you can size it, you can place it when you're doing a capsulotomy, whether you want it on the capsular center, whether you want it on the pupil center, whether you want it on the limbus center, or whether you want to customize. So a manual CCC versus a CCC which is done by the femtolaser, these are the differences which could be there. So what it translates to is the precise shape, size, and centration of the IOL being very stable. ELP can be measured much better, and refractive predictability is there, as also it is supposed to minimize the risk of PCO. So when you know that you are wanting to reach target emetropia, the A constant of the lens is calculated basis where the lens is going to sit at the end of the procedure. And for that, capsular excess and placement of the lens within the bag is something very important. And this is one of the hallmarks of the femtolaser which is there. And this helps you in working with better outcomes as regards a refractive procedure. Now, similarly, if you go on to the more premium intraocular lenses, that is the trifocal lenses and the toric intraocular lenses or a toric trifocal lens, the window for error is quite small and you don't want any tilt, decentration or rotation which is there. And therefore, the capsulotomy being very accurate is thought to aid in the IOL centration, which is an important thing which is there. Now, this is the machine that I normally use. And you can see that this comes with a bed. There is the foot switch to fire the laser. There is a foot switch by which you can put on the vacuum or release the vacuum. There is this screen that comes where you can actually look at entering the data as also what procedure is going on, and this is how the box looks. There are also buttons here which help you capture, help you do the alignment, which I'll just show you. Now, our journey, I think, has been pretty large. I think we have worked with more than 10,000 cases over 6 years. And we started with the LensX system. We started with the LensX system about, sorry, this should be not 6, but I think it is about 10 years ago. We started with the LensX system, which was a hard dock. And one of the things was that capsulotomy would not come as perfect as it comes today because of the hard dock. When the dock came on to the patient interface, came on to the cornea, there were posterior corneal folds that came. And once posterior corneal folds came, this would give rise to skip areas because the laser was not able to penetrate through the posterior corneal folds. And then came the advancement within the LensX system in which there was a soft fit PI. That means that the undersurface of the PI, a soft contact lens was put, which was quite thick, which reduced the indentation of the cornea. But then we moved on to the catalyst system, which had what is known as a liquid optic interface. That means that there is no direct touch on the cornea with the patient interface, but there is the contact through the balanced salt solution or the ringer lactate or whatever you put the fluid onto the interface, and through that the laser fires. This makes the laser giving you perfect capsular access. It gives you a very fast capsular access, etc. So this is minimal assistance required. So you can see this is how it is. This is the, so there are two parts to the what is called as the LOI. LOI stands for liquid optic interface. So this is the liquid optic interface that goes on the cornea. You can see a tube going which will give the suction on so that the eye gets lashed on to the patient interface, and this goes onto the undersurface of the laser, and then this goes in, and this is how, without touching the eye, this is going to be where the laser is going to fire. Now let me just show you in real time as to how this is done. So you can see this is a red line. The eye has to be aligned within this. This comes into the green area. That means that your suction is adequate. The pressure on the eye is adequate, and then this gets locked. So then a 360-degree OCT is always an integral part, and OCT is always an integral part of any femto laser for cataract surgery. Now, this is giving you an error. That means that where you have put the cataract incision, they are intersecting the iris or the lens. So these are kind of errors that keep coming. And you can see that this is the OCT which is there. The anterior cornea came. This is the lens which is coming. You can see anterior lens, and then you will see the posterior lens. This is showing you that you are making it a softening, and this is the incision which is coming. So you can size the incision, you can place the incision on the steep axis. The new softwares which are there would identify the steep axis, and you can place the incision on the steep axis as you wish that you would want to place it. You can see this is a very fast capsular access that has happened. And then you can see that it is nucleotomy which is coming. We have made 4 quadrants, plus we have made softening. This softening can go up to 1000 microns. It can be as low as 100 microns. So you can actually fragment the nucleus to as size as you want, whatever size you can want. More are the fragments, that means smaller are the fragments, it takes a little longer. Nowadays we are not making these many softenings or fragmentation, because the idea is to crack the nucleus into 6-8 parts and to have larger segments, because the smaller segments at times get stuck under the iris. So you can see this is the incision that is being made, the primary incision which has been made, and you can see this is the secondary incision. That is, you can make 2 incisions if you want, you can make 1 incision, and you can do an LRI. Now when you enter, you can see that this is a free floating capsulotomy, right? So you can have free floating capsulotomies if you want, but in the liquid optic interface, there is an element of pneumodissection that is done. That means that you need not do a lot of hydrodissection, because you can see that the air or the plasma that has been generated, you can see the ease with which one can do a viscodissection. You can do with a phaco, and in soft cataracts, you can do a viscodissection. And all that you have to do then is that it is basically very easy to kind of aspirate with almost zero power the nuclear fragments that have been made, and it is really something which reduces the amount of phaco energy that you are requiring to actually suck out the entire nucleus. Once you have removed the nucleus, as you can see in this particular case, then you will actually go in with a irrigation aspiration and you can take out the cortex. The important thing in the cortex removal is that because the laser has passed through the anterior cortex, it is kind of given a cleavage of the cortex. So you have to go below the capsule to take out the cortex. Now, this is having come a long way from flax, which I said that we started doing in 2014. This is where we are today, from couching going on to, as I told you, ICC, ECC, Phaco, and flax. So this is where the journey is today. Now, I've told you the principles as to what all the femto does, what is a femto, what are the basic points, the liquid optic interface, the applanation, and what do you actually do, or the process through the OCT, etc. guidance, you can see as to where exactly you are wanting to do the nucleotomy, etc., etc. But now let us move on to a little more difficult situation. That is, there are the routine cases, but the important thing is that whenever a new technology comes, you should be able to actually simplify the challenging situations which are there. Now, first of all, what are the challenging situations where there is a contraindication? I would say corneal opacities and pupils which are not dilating. These are two important things because the laser will penetrate only through clear media. If the media is not clear, then the laser will not be able to penetrate. If the pupil is small, it is not going to penetrate. So you can't do much about corneal opacities, but if there is a small pupil, you can put in a Malyugin ring, or you can put any other Bhattacharjee ring or whatever it is, and come back on the machine and then do the laser, because then the pupil is cleared and you can go ahead and do the rexes and the nucleotomy. The second thing, which also is a contraindication, is that if you have emulsified oil, so this is ideally also something like a corneal opacity or something which is blocking the laser from going in. Now, apart from these relative contraindications or gross contraindications, there is very little that obviates you to use a femto laser, apart from, again, the cost consideration which is there. Hopefully the costs have come down and they should come down further. Now let us just look at specific situations where the femto laser helps you. So if you are looking at a posterior polar cataract, as you all know, this is the typical appearance of a posterior polar cataract. You have this onion peel appearance, etc. And there is, in 30 to 40% of the cases, a pre-existing weakness in the posterior capsule. So what happens is that when you are doing a phacoemulsification and you are not alive to the fact that there is a posterior polar cataract, you just do a cortical cleaving hydrodissection, and that can cause a hydraulic rupture of the posterior capsule. But if you compare it with a femto laser, in a femto laser assisted cataract surgery, there is pneumodelineation that happens. So you don't need to do a hydrodissection because there is already a pneumodelineation that has happened. And this really eliminates the pressure rupture that you can get with the fluid coming in. Now, the femto laser also gives you a disassembled nucleus. It gives you a fantastic capsular axis that even if you have to put the lens in the ciliary sulcus, the capsular axis is very strong. So this is the biggest advantage, that you visualize. I'll just show you. You visualize the lower part of the posterior part of the nucleus, see as to the pre-existing defect, and then work on it. So this, I'll just show you. This is an OCT image that you get in a posterior polar cataract, and you can see here that this is a posterior capsular pre-existing defect. That means that the OCT is able to tell you if there is a pre-existing defect which is there or not. Now, again, when you are doing this, when you are doing the femto laser, you just see that you have to actually see that the dissection of the nucleus is only in a zone where you are leaving behind the epinuclear cushion. So you see these bubbles that I have moved up. Once you have moved up these bubbles, you can see that these are the bubbles which are lying here, and the dissection has been done only in the blue part. So we have reported this, that the anterior segment OCT which is there, this can help you detect pre-existing posterior capsular dehiscence and this would increase the safety in posterior polar cataract because the nuclear disassembly has happened, and it is only at the very end that you have to lose the continuity of the posterior capsule. Let me just show you this case. This is a slit lamp image. If you see posterior polar cataract, huge dehiscence which is there, you can make out from the right on the slit lamp. So how would you tackle this on a phacoemulsification is the problem that you have, because you are likely to get a nucleus drop. But ever since the femtolaser has come, the chances of having a nuclear drop go down very significantly. So just see this, that we are doing the docking. This is the big defect that you have of the posterior capsule. Can you see this at the arrow? And then we move the bubbles up. So these bubbles are moved up, as you can see here. And then we are making 6 quadrants, a capsulotomy, good enough capsulotomy. You can see you have a great capsulotomy, you have a nuclear disassembly, you have that dehiscence at the back. And this is the intraopacity, where you can see that this is the place where there is the dehiscence. Now, without doing any hydro procedure, we have been able to remove this disassembled nucleus. There is a great epinuclear cushion which is there. You can see this is a huge epinuclear cushion which has been left. And we are doing irrigation aspiration without actually disturbing anything till the very end. And you can see that it is only at the very end that we are seeing and you can see a vitreous blob that is coming. And therefore, you can go ahead and put the intraocular lens in this case. So this is just a photo essay of the same patient that I showed you. So this is slit lamp picture. This is the picture that you get even on the IOL master. And then you can easily see on the on the femtolaser, you can see this is the picture that you have. This is the defect. The blue area is the area where you're going to do the femtodelineation, and the rest of the area which is here will work as a scaffold because of the epinucleus. And once you have the epinuclear cushion, you don't lose the posterior capsule till the very end. And this is the situation when everything, you have a big defect which was there right from the beginning, which you can see. So you are seeing a vitreous blob that is coming, but you don't have any vitreous loss which is there. So the epinucleus, because of the femtolaser visualization, works as a shield and gives you precise, sharp but smooth pneumodissection. And the nucleotomy, you can actually raise the default setting from 500 microns to 1000 micron away from the posterior capsule. The thick epinuclear layer acts as a shield for the weak posterior capsule from the mechanical and turbulent forces during surgery. And nuclear rotation can be done without disturbing the posterior capsule, because there is a delineation that has happened of the nucleus and not a dissection that has happened, and the epinuclear cushion is there. So this is like if you are banging a car without airbags and you are banging a car with airbags, you can see the safety, and the driver is not going to get hurt in this particular case because of the advantage of femto which is there. Now, as I told you, the kind of contraindications, one of the contraindications, as I told you, was a small pupil, but you can go ahead, as I told you, that you can place a Malugin ring, go back and then do the femtolaser in this particular case which is there. Now, I'll just show you in real life. This is the small pupil. The entry that is being done. Once the entry has been done, you can see this is the Malugin ring which is there. Once the Malugin ring has been put, either you can wash the viscoelastic or you can put the viscoelastic and increase the power. And then you can see here, this is the subluxated cataract. You can see this is a subluxated cataract. And you can see this is a capsulotomy which is there, which has been done 5.5 millimeter capsulotomy, and the nuclear fragmentation which is there. Now let us just look at the Phacomorphic glaucoma, another indication where one would ask you which is the treatment of choice. The treatment of choice here is If you do a phacoemulsification in this particular case, you can see the huge tense capsule which is there. So I'll just show you. Can you see this huge tense capsule which was there? Sorry. See this. So you can see this is a huge intumescent cataract. You can see that there is a liquefaction of the cortex. You can see that the back of the cornea and the iris, there is very little space, and that is, you can see here, this is where the one can say that this was a phacomorphic glaucoma. So now the advantage in a phacomorphic glaucoma is that you are actually working on a closed chamber. Okay, so this is a closed chamber. Just look at how the fluid gush came out. This is the LRI, this is the primary incision which is there. But the whole thing is that you can use trypan blue because there may be skip areas, but you can get an absolute good capsular access in this particular case because you have worked on a closed chamber. Having worked on a closed chamber, the chances of a runoff or an Argentinian flag sign almost dissipate or become near zero. Now, when you are looking at a rock hard cataract, another case where you can, we were taking the patient in, and I was advised by one of my associates that we should not tackle such a hard cataract with femto. We should actually go ahead and do an SICS. But then, then you can see in this particular case, we went ahead, did a larger rexes because the nuclear fragments will be bigger. And you just see here, can you see these bubbles coming out? So these bubbles that came out in this black cataract, you can see it is a pre-chopped cataract. And once you work on this pre-chopped cataract, the amount of energy that you require, it adds a huge safety margin in this, and the amount of energy that you want to use or that you use is significantly less in these cases. And you can see we finished the surgery. Now, another situation where you can get excellent result is post-traumatic subluxations or any subluxation. You can see that here, when you are having a subluxation, these zonules are lax. And once these zonules are lax, you don't have a counter traction or a counter pressure for which to do or complete a capsular access. But this is not required in case of a femto laser because the femto laser is a cutting laser. So it just comes and hits on the capsule wherever you are positioning it. So if you are working on this particular case, say a pre-op this thing, so we have described that you combine it with pars plana because there is vitreous in front of this, and you can go ahead and combine it with a pars plana vitrectomy, which I call as the third hand, and we can optimize the surgical outcomes in these subluxated cataracts. So let us just watch this. This is the OCT image. Can you see this iris coming down? This is the iris which is coming down here. Okay. So once you have this iris which is coming down, this is the vitreous blob. You can see that the lens is more globular than it should be. So this is the situation where we are looking, and we will be able to center the capsulotomy where we want. So this is the posterior capsule, anterior capsule. You just watch here. Could you see that? So basically I did it. I do not want it on the center of the pupil now, because once we put the ring, the capsule will move towards a particular size. So what we are doing is that we are customizing the capsulotomy or customizing the center. And we have gone in through the posterior route. And once we have the nucleotomy, the capsulotomy, etc., we put tricot, and this is the vitreous. You can see vitreous wing is coming here. We bring the lens, the vitreous to stop pushing the lens. And it is much easier. We can put in that particular stage the capsular tension ring. And you can see that the lens goes back in its position, and you are able to actually go ahead and complete the phacoemulsification procedure. And now this is a bimanual irrigation aspiration that one is doing in this particular case to get good results which are there. Okay, so again, fantastic technique for subluxated lenses, and you can put a 3-piece lens to get a good result. So this is the post-traumatic subluxation where you can see an excellent post-op result, which is this. So friends, this is a couple of indications that I'm giving you, contraindications. I have told you the whole procedure, the amount of time that is taken for the laser is, I would say, less than a minute. And you can actually, it is very intuitive. Now there are newer softwares which can actually match with the Callisto system or with the IOL master. You get the image where the new software which is there. I haven't gone into details of that, but the new software which is there is allowing you to actually have the IOL master 700 image, pick up that image onto the Catalyst system, and you will have the alignment that you can do of the LRI. You can align the incision, and you can also have toric alignment marks. That means that you get marks on the cornea, so that even post-op or on the table, you can align the toric lens. Similarly, Lens AR is another machine where they make small knuckles or small kind of annular this thing on the capsulotomy, again on where the toric IOL has to be placed. So both the toric marks on the cornea, as in the Catalyst system or the capsulotomy, these will be available to one even in the post-operative period, as to this is where the lens alignment was to be, this is where the lens alignment is, and that this is a big step again to get better outcomes in the toric lens. Then apart from that, what you are getting in the new thing is that this is automatically throwing up the LRI nomograms so that you can do. Again, AI has been introduced in femtolaser assisted cataract surgery in the machine, say in the Lens AR, it is likely to come in the Catalyst, etc., where the image is graded by the OCT and by the machine to say as to what should be the pattern of nuclear cutting in these cases, so that you get excellent outcomes with minimal amount of energy in these particular cases. So friends, this is what I would wish to say, that as the technology of femtocataract has evolved, it has found widespread use not only in the routine cases but in complex cases. And it is time to, one would say, that take the leap of faith in our centers. My personal penetration of femtolaser would be higher than 70% at a group at Sachdev enclave, where we do a lot of femtos. Our penetration has gone up to about anywhere between 45 to 55%, depending on which month you are operating. So that is the kind of power of the laser that is there. The outcomes have become better, and the amount of energy that you are using is less. So therefore, the corneas are clearer, as also the capsulotomy is fantastic, and LRI is used for reducing the astigmatism. I normally don't go more than 1.25 diopters for reducing the capsulotomy. So this is what I will wish to say. Ran you through a gamut of surgical cases, advantages, etc., and where all you can get excellent results with the femtolaser technology. Thank you very much.
Thank you very much, sir, for a very enlightening talk. And now I would request Rishi sir to please put some additional notes or anything that he would like to comment upon. Thereafter, we'll be asking Dr. Garvita to see if there are any questions from the students.
Well, thank you, Dr. Mahipal. I think it was a comprehensive coverage. Appreciated that talk. You even gave us the whole evolution of cataract surgery, coming up all the way to this highly efficient technology that we have now available to us. Now, I think femto has certainly, and the cases that Dr. Mahipal showed with the posterior polar, the subluxated cataracts, the suprahard, the cataracta nigras, that's where the real value of this machine lies. And the penetration will certainly get deeper and deeper as we understand what all it can actually contribute for the safety as well as the better outcomes, especially in premium IOLs. So I think with premium IOLs, it'll also find place in acceptability as far as patients are concerned. So I had actually a set of questions of my own that I would ask Dr. Mahipal. So I noticed that at some places you would just want to make radial segmentations, and at some places you would want to do softenings and create a grid in the nucleus. What determines this choice? So which kind of patients would you like to soften the nucleus, and where would you like to just leave them with radial cuts?
Okay, so basically, what is the problem? The idea is that when you're doing a softening, you are actually able to make it into such small pieces that you can just suck it out. But the disadvantage is that you don't get purchased with a phacoemulsification probe. That means that it is so soft that it just goes through it and you don't get a vacuum seal. So basically, in a hard cataract or a supra hard cataract or whatever it is, under those circumstances, you can actually ideally make 6 or 8 cuts or whatever you want. You can even make 12 cuts. But making these small fragments actually will not help you get at the meat or center of the nucleus, and the separation, the backbone would still be stuck because you will be taking out these. So I normally, when I'm going on to hard cataracts, I do not make these small pieces or the softening. It is basically 6 or 8 fragments that I do, as I showed you in that rock hard cataract. And in softer cataracts, as I showed you, where we did a visco dissection, you are just aspirating. That is where you can do these softenings as you wish.
Right. I have a couple of questions before I hand you back to Dr. Kiran and to Dr. Garbata. So we mentioned the offset and how we would like to change the offset in these posterior polars. Are there any other situations where you would want to change the offset from the posterior capsule?
Not that I can think of. Basically, wherever you are, basically wherever you feel that the posterior capsule may be friable, like basically aaj ki tarikh mein everyone is, there are lots many intravitreal injections that are being put. Under those circumstances, you may feel that at times the needle might have injured or something like that. If there is a sudden development of cataract after intravitreal, so those are the types where you would want to keep an offset. An offset essentially allows you to give an epidemial cushion. So any place where you would feel that the posterior capsule is deficient or is inadequate, that is where you would wish to do that.
Another critical step in flax as compared to conventional surgeries is the rhexis and what happens immediately after the rhexis.
Okay.
And in my own experience, I've had to unlearn to an extent what I would normally do in my hydro steps when I would be dealing with the flax. So would you like to elaborate on that? How is the hydro steps and the mobilization of the nuclear fragments different from conventional MICS or Phaco?
Okay, the first thing, let me just go back a little step. Maybe I should have mentioned when you're doing a capsulorhexis, certain machines which have a harder dock, and you're doing a capsulotomy, there are obviously, because of the dock and because well, it's a kind of a surgical trauma or whatever, you can see there's a dock, and because of the capsulotomy happening and a lot of energy being released, at times the pupil comes down on you. So that is one important thing, that you must use non-steroidal anti-inflammatory drops, which ideally you should, so that the pupil doesn't come back on you. And nowadays we have intracameral phenocaine, etc., which we can use to bring down the pupil. So the time interval between your cutting and your doing the procedure should be slightly less. But when you're looking at a liquid optic interface, the pupil doesn't come down at all to that extent as compared to a hard dock. So that was just by the way, because you talked about the pupil. Now, when you're doing a hydrodissection, the only important thing is that you have already had a pneumodissection. Some people say that they don't even want to do anything. The fluid, you need to do very little squirting, and then you need to depress as you depress in the other thing, and you get a complete around that. In a posterior polar, because you have the offset or wherever you are, the hydrodelineation is a pneumodelineation that has happened or a pneumodissection that has happened. So the quantum of fluid that you are using is very little. So you don't push in a lot of fluid. You push in little fluid and you just depress it. And you will get very good mobility and the freeing up of the nucleus which is there. So that is there. The second thing which I talked about was when you're doing the cortical cleaving, that is cortical cleanup. See, what happens is that the laser has to pass from the top. So what is the first thing that comes? That is the capsule. Then you have the cortex. So
Correct.
the cortical fibers are cleaved. Okay. So you don't have a purchase again of the cortical fibers. They don't come the same way. They don't come towards the center for you to pull them out pretty easily. So you have to actually go in the bag under the capsule to pull out these fibers. So at times a bimanual may be better than that. But then you should take it out. If I start from this, I should keep on taking out the next cortex, and this just keep things removing. So these are the basic differences as regards the nucleus and the cortical aspiration, and as also the people coming down on the femto platform at times after the capsulotomy. Otherwise, sometimes the capsulotomy can get lost. If you have not taken it out, it's always a good thing to take it out. We normally get free floating capsulotomies or capsulotomies where there is very little this thing in the liquid optic interface. But whenever in doubt, just put trypan blue. For example, in intumescent cataracts, when there is fluid coming out, under those circumstances, because as the fluid comes out, because the capsulotomy is still going over it, it is still not completed. So there could be skip areas or postage stamp areas. So you need to put trypan blue in these cases so that you can visualize if there are any skip areas, etc. The other problem which is there in the femto is the machine does not allow you, if you lose suction, or if there is any problem, or you lift your foot switch during the capsulotomy, it will not allow you to do a recapsulotomy. So it is better in those cases to not proceed and not do a nucleotomy, because your red flow gets compromised if you go on to actually do the nucleotomy without the capsulotomy having been done. So that is another thing that you have. You can go ahead and do the, you can silence off the nucleotomy, and you can go ahead and do the incision, and you can do the LRIs.
Wonderful. So you actually anticipated my next question by telling us about the fact that the cortex gets sliced and you don't have purchase from beyond the capsular rhexis margin. You have to go and actually find these fibers from underneath the rhexis edge before you can engage. And a bimanual in such situations is probably a better option for which you may need more than one side port. So that's one more thing that I would normally do, is to create more than one side port. And it's just easier than to manipulate these smaller, finer instruments. So excellent again, Dr. Mahipal. I'll hand you back to Kiran and to Garvita to carry on with the questions that we may have received.
Thank you very much, sir. Dr. Garvita, do we have any questions?
Yes, ma'am, we have a few questions for sir. So the first question is there any significant IOP change during docking that needs to be taken into account?
Yeah, so there is an IOP increase. Obviously, whenever you are doing anything, whether you're doing LASIK, wherever there is suction that is applied to hold the eye, one of the things any of these lasers or anything that requires is immobilization of the eye, because there is a precise kind of a picture that you get, and a precise focusing on that particular area. Because if the eye is moving, then basically the area where the OCT has picked up and you want the laser to fire will not be there. So whenever you are applying suction, there is going to be an intraoperative increase. There is obviously in very extreme glaucoma, people will say etc. etc. But we have done it even on filtering plebs. You can see the filtering pleb. You can go ahead and do that. Because the liquid optic interface causes the pressure to go up only up to 30 millimeters. But the other ones allow it to go up to 60 millimeters. So yes, there is a transient pressure rise for the time that is there. So that is where you can actually, if you do it pretty fast, how intuitive the machine is, the time taken for etc. for the total procedure comes into consideration. But by far, there are very few, I don't know, I have not searched the literature, but I have not had a snuff out in these cases with the liquid optic interface.
The second question is, sir, what are the pre-operative and intraoperative precautions to be taken in femtosurgery in cases of Fuchs endothelial dystrophy, sir?
Pre-operative, so basically intraoperative or whatever, when you're doing Phaco, you'll use chondroitin sulfate, etc. Then when you are doing the laser, there is nothing specific. The only thing is, people say that because of the areas where there is loss of the endothelium, there could be malfocusing But there's nothing much that you can do. I don't take any special precautions during the femto procedure because there is none that you can really take to do that. The amount of energy that you use should be the minimum, and definitely it is a procedure of choice in Fuchs because the total energy that you are using in the fractionation of the nucleus, etc., is much less. Yes, one of the things that I would wish to do is that when you are doing with hard cataracts, etc., or otherwise, there can be multiple passes that go into the nucleus to fragment it more. So maybe to reduce the energy that is being going into the eye, you could reduce the number of passes for the nucleotomy which is there.
Yes, sir. Sir, the third question is there any situation where we prefer opta cuts of nucleus instead of conventional quad cuts?
I didn't quite follow the question. OCT, when you are getting the 8 cuts, you are talking, okay, octa, sorry, it's not OCT, this thing. Okay, so this is 8 cuts of nucleus instead of conventional quad cuts, obviously in hard cataracts. Very hard cataracts because you need the nuclear slices to be smaller so that you can break them easily and suck them out. I think that's what the question possibly is. So grade 2 cataracts up to grade 3 cataracts, I will do 4. And as I go to 4 and 5, I will increase and you could go up to even 12. But typically, I don't go more than 8 cuts.
Excellent. One question from YouTube, sir. Question says, can femto laser be used in all age groups?
Oh yeah, it can be used in all age groups. We have done it in kids also. You can give them a little sedative. People have done it under general anesthesia. And the next big thing in femto is to go back and also use it for posterior capsular rhexis in congenital cataracts. So that is something I don't know whether people are aware of it, but femto is now being used even for retina, for the membrane, etc., for cutting the membrane, etc., even for epiretinal membrane. So these are the next things that are there. The delivery obviously has to be different. But yes, it can be used for these particular situations. Posterior capsular rhexis, there are definitely papers because they're doing a posterior capsular rhexis in a kid is much more difficult than if you require to do it in an adult. So you can do it in for pediatric cataracts, you can do it. And you can do a femto in any age, that's really not a problem. That again is an advantage that the elasticity of the anterior capsule is also there where you have to pull the rhexis in case of a kid, that would not be required. But yes, you have to do it under general anesthesia, which there are a lot of institutions where the femto laser and the phaco machine are kept side by side. One of the other things that is possible maybe in the next 5-7 years is that the phaco machine will be part of the femto or it will be one box where you can actually do it and you can do it under anesthesia and do it. That's really something that it can be done in all ages.
That's all, sir. These were all the questions available.
Okay.
Thank you, Dr. Gavita. Sir, I would just like to ask that when we are using femtolaser for LRI, for a limbal relaxing incision, do we raise the bar on our toric requirements or it still stays the same? Toric IOLs, I mean.
No, toric IOLs, I am telling you, I use normally 1 to 1.25 because that comes within the cost for the patient for the femto. So I am not charging them extra. Actually, today only I was talking to some of the IOL manufacturers. And, one of them has come out with the T2 version or the T3 version at a 30% discount. Ideally, toric should become standard of care, and I think Dr. Rishi is somebody who's really pushed very hard for getting towards emetropia. So whether you are doing the LRI or whether you are doing the toric version, because there is a cost saving, I personally feel that I would not wish to go because then there is the kind of regression which you can get in higher this thing. But one thing that one has to remember about the astigmatism is whether it's with the rule or against the rule, and how forgiving is that astigmatism going to be. So you need to be aggressive in say against the rule, but not be aggressive with the rule. And where you are, if you're leaving behind a little bit of astigmatism, it's actually good for reading for the patient. So my bar is about 1 to 1.25, and above that, I have switched over to the lens-based procedure. That means toric IOL.
Right, sir. Thank you, sir. And you also showed in your video a case where there was a vitreous blob. Does the vitreous blob also tend to interfere in the passage of the laser?
That is the biggest advantage. The only thing, if you know that there is a large amount of vitreous, you can increase the energy for the capsulotomy. That's about it. That is the advantage, that it can, anything that is optically clear. If there is something in the vitreous, that's something different. But anything that is optically clear. Similarly, what I would I didn't mention, but I would wish to mention here is that if I have a white cataract, the nucleotomy would not go through a white cataract because it is not focusing. But even if you have a dark brown or a black cataract and there is a focusing that is possible, it will cut through it. That's what you saw in the black cataract, and that's the air bubble that I showed you that's coming out. That means that the plasma has been generated on the undersurface and they came out when you did the nuclear disassembly, which is there. Okay.
You're muted, Kiran.
Kiran, you're muted. Yeah.
Sorry, sir.
Yeah. You were saying something.
You were saying something, we lost it.
You are muted.
Sir, I was saying we thank sir for an excellent session. And I request Rishi sir to give a word of thanks to Mahipal sir and give concluding remarks.
No, it was absolutely awesome. I learned so much. I always do when Dr. Mahipal is speaking. And like I said at the beginning, it's worthwhile for every resident and everyone who's hearing this talk to actually take away these nuggets from Mahipal's presentation in terms of, his vast experience with flax. On the toric front, Mahipal's quite right. I was very, very instrumental in pioneering the acceptance of torics being used in premium IOL care in the monofocal segment. And I have now pretty much thought that anything more than 1 or even 0.75, if it's against the rule, should really be looked at as a toric candidate. These patients are so much happier because of the correction that we're able to give. And with the newer types of lenses, the stability of the toric rotation is very, very low. And so I think that is something that comes in. LRIs certainly make a difference. The only problem with LRIs in the against the rule segment is that they're in the 0-180 axis. And there are people who will sometimes complain of a dysphotopsia because the LRI is made at a much lower or a much smaller optical diameter. And so that is one thing, again, that and many of the patients that we use toric lenses are actually against the rule in that age group. They are far outnumbering with the rules. So I don't know if Dr. Mahipal has anything to say about that specifically.
I think that's a neat observation that you're making, that yes, that's where it is. But you can easily make the incision, but yes, then there could be, you need to reduce it outside the incision. That's about it.
So wonderful talk, greatly appreciated, I think, by everyone. And nice discussion too from the questions that we've had. And you've summed it up and very beautifully presented us the whole gamut of flax. And I'm sure we'll all learn from this. So thank you all very much
Thank you
for this evening.
Thank you very much, sir.
Thank you.
Thank you.